If an adult's resting heart rate suddenly spikes to like 160 beats a minute, alarms go off.
Oh, absolutely. It's a massive red flag.
Right, it's an immediate, undeniable warning sign. But if a toddler's heart does the exact same thing, well, they might just be furious that someone took their toy away.
Yeah, exactly.
Welcome to a new deep dive.
When a child is in danger, medical providers rely on these bespoke algorithms, intricate clinical math, and physical interventions that would literally never apply to you or me.
So for you listening, if you want to understand the hidden logic doctors use when every single second counts, this is really your masterclass in human biology. We're taking this stack of clinical data and looking at how providers identify a crisis when, their patients often can't even speak.
Yeah, that's a huge hurdle.
Assessing a preverbal infant in an ambulatory setting just seems incredibly daunting. I mean, the provider has to somehow differentiate between a benign viral infection and a life-threatening emergency in a patient who is just crying constantly.
Right, and that ambiguity is really the foundational challenge of pediatric triage. Hospitals utilize tools like the Emergency Severity Index, or ESI, tailored specifically for the pediatric population.
Okay.
It creates this really rigid hierarchy. So level 1 patient requires immediate life-saving intervention. Perhaps they're in cardiac arrest or experiencing profound bradycardia, which is a super slow heart rate.
Wow, okay. And the other end?
On the other end of the spectrum, a level 5 patient simply needs a routine history and physical exam. But the real difficulty lies right in the middle, navigating those vital sign paradoxes you mentioned earlier.
Like the tachycardia, the fast heart rate.
Exactly. Tachycardia being the prime example. A fast heart rate is just so common in children for completely benign reasons. I mean, fever drives it up, crying drives it up.
Just being anxious in a hospital room drives it up.
Yes. Yet that exact same tachycardia is also the earliest compensatory mechanism for severe, life-threatening shock. The body's desperately trying to maintain cardiac output.
So a clinician can't just look at the monitor and know what's going on.
No, they really can't. They have to interpret the data through the lens of the child's behavior. They rely heavily on the clinical picture of irritability.
What does that look like in practice?
Well, consider a child presenting with a high fever and a racing heart. If you administer an antipyretic, like Tylenol, to bring the fever down, and the child subsequently calms down, looks around the room, maybe starts playing with a stethoscope,
Then you're in the clear.
the clinical picture is reassuring, yeah. The tachycardia was just a physiological response to the fever. However, if the fever breaks and the child remains inconsolably irritable, or worse, progresses to lethargy.
Oh.
Yeah, the diagnostic algorithm shifts drastically. That persistent alteration in mental status is a blaring siren for invasive bacterial infections like sepsis or meningitis.
So the physiological warning lights stay on even after the initial trigger is removed.
Exactly.
And speaking of warning lights, the sources detail this deeply unsettling cluster of symptoms called the Cushing triad.
Oh, yes. The Cushing triad.
It presents as bradycardia, the slow heart rate hypertension, so high blood pressure, and altered, irregular breathing. Mechanically, this just seems entirely counterintuitive to me.
How so?
Well, typically, if systemic blood pressure spikes, doesn't the heart race to accommodate it or drive it? But here, the pressure is sky high, but the heart is slowing down.
Right. It's the mechanism behind the Cushing triad is this brilliant, albeit terrifying, display of autonomic survival. Those 3 signs indicate a life-threatening increase in intracranial pressure.
Pressure inside the skull.
Yes. Whether it's from severe trauma, a tumor, or catastrophic swelling, the pressure inside the rigid skull is rising. So the brain tissue is being physically squeezed. And crucially, it begins compressing the brainstem, which houses your respiratory and cardiovascular control centers.
So the body basically realizes the brain is being starved of oxygenated blood because the pressure inside the skull is actually higher than the blood pressure trying to get in.
Precisely. It's a mechanical flow problem.
Yeah.
So the sympathetic nervous system triggers massive peripheral vasoconstriction. It intentionally drives the systemic blood pressure dangerously high to overcome that intracranial pressure and just force blood into the brain.
Oh.
But then, and this is where it gets crazy, the baroreceptors in the aortic arch detect this extreme hypertension. They send signals via the vagus nerve to reflexively slow the heart rate down to protect the system.
Oh, I see.
So you get profound hypertension coupled with bradycardia. Meanwhile, the physical crushing of the brainstem disrupts the neural pathways controlling the diaphragm, and that's what results in the irregular breathing.
That is wild. They are reading the mechanical failure of the brain entirely through the cardiovascular and respiratory systems.
Exactly. And they use pupillary responses the exact same way, looking at the eyes as a direct window into the cranial vault.
Right, because the eyes are physically connected.
Yeah, pupillary assessment is rapid and highly localized. Finding pinpoint, highly constricted pupils can immediately point a provider toward an opiate ingestion. Or, structurally, a lesion specifically in the pons, which is a very specific section of the brainstem.
And what if the pupil is enlarged?
Conversely, a unilateral blown pupil, where one is massively dilated and fixed, indicates uncal herniation.
Uncal herniation, what is that?
It means the intracranial pressure has reached a point where a portion of the temporal lobe is physically herniating or bulging downward. It compresses the third cranial nerve and literally paralyzes the pupillary sphincter muscle.
Oh my God.
Yeah, it dictates immediate, highly aggressive intervention to reduce the swelling before brain death occurs.
Which fundamentally dictates the order of operations when responding to a critical patient, right?
Less.
Like, the standard primary assessment we always hear about is A, B, C, D, E, airway, breathing, circulation, disability, and exposure. And in adult medical dramas on TV, the climax is always the heart.
Always.
The monitor flatlines from a massive heart attack, the team yells clear, and they focus entirely on circulation. But the pediatric protocols flip that hierarchy on its head.
They have to. In children, sudden cardiac arrest is almost never a primary ischemic heart issue.
That's the part that really surprised me.
Yeah, this pediatric paradigm shift is recognizing that a child's heart is generally structurally sound and healthy. Pediatric cardiac instability is almost universally a secondary consequence of respiratory failure.
So the lungs fail first.
Right. The heart doesn't just spontaneously quit, it slowly starves. It's subjected to prolonged hypoxia, lack of oxygen, because the airway has failed.
Got it. So securing the airway becomes the absolute non-negotiable priority. I mean, you can perform flawless chest compressions, but if you haven't fixed the lungs, the heart will remain locked in arrest because the muscle tissue itself is completely devoid of oxygen.
Exactly. And navigating the pediatric airway introduces immediate anatomical hurdles. The providers have to distinguish between upper and lower airway obstructions based on acoustic and mechanical clues.
Like how they sound.
Right. An upper airway obstruction involving the larynx or trachea, think severe croup or, a child who aspirated a foreign body, typically produces stridor.
Stridor?
Yeah, that is a harsh, high-pitched turbulence heard primarily during inspiration, when they breathe in.
Because the turbulent airflow is hitting the narrowing as the chest expands and pulls air down.
Got it. Whereas lower airway obstructions, like asthma or bronchiolitis, happen deep in the bronchioles. Those present with wheezing during expiration, as the airways naturally narrow when the child breathes out.
So what happens when those non-invasive measures fail?
Well, if a provider must artificially secure the airway, they move to intubation. But here's the catch. Because pediatric patients range from premature infants to full-sized adolescents, there is no standard equipment size.
Right. A preemie and a 16-year-old are vastly different.
Completely different. So providers utilize clinical math under extreme cognitive load. For an uncuffed endotracheal tube, the standard formula is the child's age in years divided by 4 plus 4.
Okay, let me do the math. A 6-year-old divided by 4 is 1.5 plus 4. So they pull a 5.5 millimeter tube.
Exactly.
And they're running these calculations in their heads amidst blaring alarms and a coding patient.
They must. It has to be second nature.
Yeah.
And the nuance deepens, too. If they opt for a cuffed tube, which features a small inflatable balloon at the end to create a tighter seal against the tracheal wall, the formula changes.
Oh.
It requires a tube 0.5 millimeter smaller to account for the physical bulk of the balloon. This protects the delicate pediatric subglottic mucosa from ischemic damage.
Wow. But inevitably, the last domino does sometimes fall. If the prolonged hypoxia causes the heart to fail, the focus shifts from assessment to mechanical life support, right?
Yes, unfortunately.
And the pediatric basic life support algorithms, the BLS, aren't just guidelines. From the sources, it looks like rigid, highly optimized physical engineering designed to artificially generate cardiac output.
That's a great way to describe it. The physics of pediatric compressions are strictly quantified. The depth must be precisely 1/3 the anterior-posterior diameter of the chest.
1/3?
Yes. That translates to approximately 1.5 inches for infants and 2 inches for older children. It requires enough force to literally squeeze the heart between the sternum and the spine.
But I'm guessing you have to be careful not to just hold it down.
Exactly. It must be controlled enough to allow full chest recoil, which is literally the only way the heart chambers refill with blood. If you lean on the chest, no blood enters the heart for the next pump.
And the ratios dynamically adapt based on the resources in the room, right?
Right.
Like a single rescuer operates on a ratio of 30 compressions to 2 rescue breaths. But the moment a second provider arrives, the protocol mandates a shift to 15 compressions to 2 breaths.
Yeah, think about why that shift exists.
Well, it goes back to the paradigm shift we established earlier. The root pathology is hypoxia.
Right.
Dropping to 15 compressions means they are pausing to ventilate the child twice as frequently. They're aggressively addressing the oxygen starvation, which is the actual underlying cause of the arrest, rather than just treating the symptom of a stopped heart.
That's exactly it. You have to fix the hypoxia.
Yeah.
And the physical mechanics of delivery change as well. A single rescuer performing CPR on an infant utilizes a 2-finger technique positioned just below the intermammary line.
Just 2 fingers.
Right. But when 2 providers are present, the compressor transitions to a 2-thumb encircling hands technique. Wrapping the hands entirely around the infant's thorax provides a much more consistent, forceful squeeze.
Because you're using your whole grip.
Yes. It engages the thoracic pump mechanism much more effectively, generating superior coronary perfusion pressure.
And while their hands are executing this mechanical labor, their brains are engaged in a simultaneous diagnostic algorithm, trying to reverse whatever precipitated the shock state in the first place.
Multitasking at its most extreme.
Right. Now, the sources categorize shock fundamentally as inadequate oxygen and nutrient delivery to the cellular tissues, but the mechanical pathways for how that happens differ wildly.
They do. Hypovolemic shock is the most straightforward structurally. It's a catastrophic loss of fluid or blood volume. The system simply lacks the fluid necessary to maintain pressure.
So how do they fix that?
It requires immediate, rapid administration of isotonic fluid boluses, calculated really tightly at 10 to 20 milliliters per kilogram of body weight.
Okay, so that's hypovolemic. What about the others?
Well, distributive shock, which is commonly seen in severe sepsis or anaphylaxis, is a vessel failure. The blood volume is present, but the peripheral blood vessels inappropriately dilate, causing systemic pressure to just plummet.
The pipes get too wide.
Exactly. Then cardiogenic shock is pump failure, where the myocardial tissue itself is failing. And finally, obstructive shock is physical blockage. The pump works, the pipes are full, but something is physically impeding the blood flow.
Okay, so to rapidly identify which systemic failure is occurring, providers use this mental checklist called the H's and T's.
Yes. It acts as an aggressive cognitive forcing function to prevent tunnel vision during a resuscitation. The H's stand for hypovolemia, hypoxia, hydrogen ion, which represents profound acidosis, hypoglycemia, and hypothermia.
And the T's cover tension pneumothorax, tamponade, toxins, and thrombosis.
Right.
And these aren't just trivia, you know? They're mechanical blockages that render perfect CPR absolutely useless. Take a tension pneumothorax.
A classic example.
Air escapes the lung and becomes trapped in the pleural cavity. With every single breath, the pressure in that cavity increases, ballooning outward and physically crushing the heart, preventing it from expanding and filling with blood.
Right, so you can perform flawless compressions for an hour. But until a provider physically decompresses that chest cavity by inserting a needle to release the trapped air, the heart structurally cannot refill.
Wow.
The same applies to cardiac tamponade, where fluid fills the pericardial sac surrounding the heart, achieving that same crushing effect. The providers must cycle through this H's and T's list continuously, diagnosing and treating the underlying structural failures while maintaining mechanical circulation.
Which brings us to a massive logistical hurdle. To treat hypovolemia or reverse acidosis or push resuscitative medications like epinephrine or amiodarone, the providers require immediate access to the patient's bloodstream.
Yes, they need a line.
Normally, this means establishing vascular access via peripheral veins, like the one in the crook of your arm, or larger central lines in the femoral or internal jugular veins.
Under normal physiological conditions, yeah, of course. But a pediatric patient in profound shock is undergoing massive systemic vasoconstriction.
Their body is clamping down.
Exactly. The body, in this desperate bid to preserve perfusion to the brain and heart, clamps down on every peripheral blood vessel in the extremities. The veins in the arms and legs literally collapse. They become virtually invisible and inaccessible to standard IV catheters.
The veins just flatten completely.
Yep.
So the providers are forced to bypass the venous system entirely and utilize intraosseous, or IO, access. And honestly, I had to reread this section of the protocol multiple times to ensure I understood the physics of it.
Is preemptive.
When peripheral veins are inaccessible, they utilize a specialized drill to insert a rigid, large-bore needle directly into the child's bone marrow.
Directly into the bone. The standard insertion site is the flat, anteromedial surface of the proximal tibia, the shin bone, meticulously positioned just below the tibial tuberosity to avoid damaging the growth plate.
I mean, drilling directly into the tibia sounds utterly extreme, but structurally, it bypasses the exact physiological roadblock the body has created.
It does. The anatomical genius of IO access lies in the medullary cavity, which is the spongy interior of the bone. This cavity contains an extensive, highly vascular network of venous sinusoids.
Okay.
And crucially, because these vessels are encased within a rigid calcified bone matrix, they structurally cannot collapse. It doesn't matter how profound the child's vasoconstriction or shock state becomes.
So it provides a guaranteed, non-collapsible anatomical highway that drains directly into the central venous circulation.
Exactly. The drugs and fluids enter the marrow and are swept immediately into the core.
Wow.
And the deciding factor in emergency medicine is always time. When veins are flat, attempting multiple peripheral IVs just wastes critical minutes during a code. An IO line, utilizing a battery-powered driver, can be placed, secured, and actively infusing life-saving fluids in under 60 seconds.
Under a minute. That's incredible.
It is a brutal but undeniably vital intervention, and it's born directly out of understanding pediatric compensatory mechanisms.
And that structural reality, the way pediatric anatomy dictates completely different medical interventions, applies equally to physical trauma. We've mapped out internal failures, from viral infections to cardiogenic shock. But skeletal vulnerability requires its own paradigm shift.
Absolutely.
The sources dedicate significant time to pediatric spinal injuries, which, while statistically rare compared to adults, present with entirely unique, hidden dangers.
The mechanism of spinal injury in a child is heavily influenced by their developmental anatomy. We really must evaluate the anatomical fulcrum of their spine. A young child possesses a disproportionately massive head relative to their overall body mass.
And it's supported by highly underdeveloped neck muscles.
Right.
It's the mechanical equivalent of balancing a bowling ball on a remarkably thin, flexible rod.
That is exactly what it's like. And that disproportion shifts the fulcrum, the specific point of maximum flexion and pivot, during an impact significantly higher in the cervical spine compared to an adult.
Higher up the neck.
Yes. Consequently, children under the age of 9 experience a vastly higher incidence of injuries located strictly between the base of the skull, the occiput, and the third cervical vertebra, C3.
And because their skeletal systems are still actively developing, the material properties of their spine create a terrifying diagnostic trap known as CWORA. That stands for spinal cord injury without radiographic abnormality.
CWORA is perhaps one of the most treacherous clinical presentations a provider must anticipate.
Looking at the biomechanics, a young child's spinal column is incredibly pliant. The ligaments are highly elastic, allowing the actual physical vertebrae to stretch and separate significantly during a traumatic impact, like a sudden deceleration in a car crash without fracturing.
Right.
But the spinal cord running inside that column, the bundle of actual neurological tissue, is completely inelastic. It cannot stretch.
And that difference in elasticity is the core of the pathology.
It's the equivalent of threading a delicate, fragile copper wire inside a thick, heavy-duty rubber hose.
Okay, I like this analogy.
If you grasp that hose and yank it with immense force, the rubber will stretch out significantly, absorb the energy, and immediately snap back into its perfectly normal original shape.
Right.
But the fragile copper wire inside could not stretch. It has been completely sheared and snapped in half.
Exactly. The physical bones stretch, inflicting catastrophic trauma on the spinal cord within, and then snap back into perfect anatomical alignment.
So when the emergency department takes a standard plain film X-ray...
The X-ray only shows the bones. It only captures the rubber hose.
Yes. The X-ray appears completely benign. There is no visible fracture, no subluxation, no malalignment. Hence the designation without radiographic abnormality. Yet, the child may be experiencing devastating, potentially permanent neurological deficits.
This dictates an entirely different approach to clearing a cervical spine in pediatric trauma.
It absolutely does.
A provider cannot simply glance at a clean X-ray and remove the cervical collar. They have to rely on rigorous, continuous clinical evaluation, hyper-focusing on subtle neurological deficits, reflex abnormalities, and motor function. Right. And they frequently must escalate to magnetic resonance imaging MRIs, which can actually image the soft tissue of the spinal cord to identify the hidden contusion, hemorrhage, or edema that the X-ray completely missed.
It perfectly encapsulates the entire landscape we've explored today, from the subtle systemic warning signs of the Cushing triad to the fundamental shift prioritizing oxygenation over compressions.
To the mechanical necessity of drilling into bone marrow, and finally, the hidden elasticity of the pediatric spine.
Every protocol, every mathematical formula, and every clinical intervention exists because children are structurally and physiologically distinct entities.
It forces a complete recalibration of how a provider observes and treats the patient in front of them. The diagnostic manual for adults is entirely useless when the foundational hardware of the patient operates on a completely different set of biological principles.
Which leaves us with a highly provocative thought regarding how we view children outside the walls of the emergency department.
Yeah, this is something to think about.
The medical field has rigorously documented, through decades of data and bespoke algorithms, that treating children like tiny adults leads to misdiagnoses and fatal outcomes. Biology demands tailored interventions.
Because the physics and physiology simply do not align.
Right.
So it demands consideration. If the scientific community has learned this lesson so thoroughly, in what other aspects of our society are we still dangerously operating under the assumption that children are merely scaled-down adults?
A great question.
Consider the geometric design of our vehicles and safety restraints, or the neurological expectations embedded in our educational structures, or the rigid scheduling of their daily lives. Where else are we actively ignoring the fundamental, undeniable reality of their unique biology, simply because it is easier to assume they are just like us, only smaller?
A deeply unsettling question to walk away with, for sure. It truly recontextualizes the way we look at human development. The warning lights are completely different, the underlying mechanics are completely different, and if you don't take the time to learn the specific code they run on, you are guaranteed to misread the system.